Joyce Black, and I'm very pleased to be able to present for you the second piece of the puzzle in how to safely put patients into a prone position. You just heard from Kathleen Volman about the advantages for patients with acute respiratory distress syndrome and how their ventilation and perfusion improves when they're in the prone position. My role in this puzzle unwinding is to help you to do it safely for the patient. We want the patient to be safe when they're prone and when they are lying in a prone position, as well as the safety of your staff to prevent injury to them. So the type of pressure injury that we're going to be looking at that can occur in patients who are prone is the deep tissue pressure injury. I'm often credited with its rediscovery, and some of my work started in the late 1980s, early 1990s. This is a very dangerous form of pressure injury development in that the injury itself actually starts in the muscle layer of the body and then is seen in the skin. It takes about 48 hours for the injury to actually show up in areas of the body that are well padded. Now, unfortunately, when people are position prone, there's often not a lot of padding. So these wounds show up a little bit more quickly than they would on the backside of a patient. Regardless of the timing, they occur initially and look like a bruise, except the patient wasn't in any kind of trauma. And so what was the cause of that? If you look at the next picture taken was 48 hours later, and now there's a blister there. And so people that are not aware of deep tissue injury would call that a stage 2 pressure injury. Now, it's not that either. It's actually a deep tissue injury forming deep in the tissues of the body and rapidly evolving to become a full thickness wound. So the picture of the patient after day 10 of the wound being present, this patient was on a great support surface, a good turning schedule, good perfusion, good nutrition, and it still ended up completely necrotic. So what we want to do with safe proning procedures is prevent these injuries from occurring on our patients. We know that when patients with ARDS are prone, they have a higher risk of developing pressure injury, particularly if the right precautions are not taken. So the body areas that are subjected to pressure injury in the prone position, these are areas of tissue that really are very thin or very poorly padded over the bones, particularly of the face. So you can think of the forehead, the bridge of the nose, the cheeks, the chin. You can come down the chest now, you're dealing with the collarbone, the ribs, the abdomen, the pelvis, the knees, the top of the foot. All of those are high risk areas, and this diagram does a nice job pointing out all of those areas for you. So what I'm going to ask you to do is, before the patient is prone, look at their body while they're still supine and look to see where those high risk areas are. So the skin care actually begins before the patient is prone. I want you to confirm that the patient is on a good ICU bed. That is a low air loss bed and a microclimate management bed, something that has a good surface for this patient to be proned onto. However, I know that not all ICU beds are like that, particularly when we're proning a great number of patients. So if that's the case, I'd like you to apply a static or reactive air overlay to the surface of the bed. So you're going to have this patient up on their side for just a brief moment before they're turned prone. That's the ideal opportunity to put that overlay on the bed. I also want you to plan ahead for what we call micro shifts, which is lifting small parts of the body every 2 hours in these patients who are prone. So lift that shoulder up, lift that leg up, lift the hip up, move that patient around. The commercial endotracheal tube holders that have a grid across the front really create an unnecessary amount of pressure in these patients who are prone. So change over whatever you're using commercially for an ET tube holder to one with tape. I want you to lubricate the eyes and tape the eyes closed before the patient goes over to avoid corneal abrasion. And I want you to apply dressings around the face of the patient. What you're looking at, of course, is a mannequin, but the dressings are applied correctly to the forehead, to the bridge of the nose, the cheekbones, and the chin. Because patients do not have an ability to swallow when they're in the prone position, they will have a lot of drool coming out of their mouth, and therefore you need to use a highly absorptive dressing on the chin and down under the chin. And if you don't have one, you're going to have to plan to change those dressings fairly often because they will rapidly become wet. Other areas of the body that you have looked at and determined to be quite bony, quite thin, can include the shoulder and the legs. So what you're looking at in the upper picture is a sacral dressing applied to the clavicle before the patient goes prone. And what you're looking at in the lower picture are two square foam dressings applied to the shin. The idea being that you have assessed the patient to try to determine where exactly those dressings are needed. Use the dressings you have and put them in place before the patient is turned prone. Safely turning the patient into a prone position and keeping the patient in a prone position does increase the risk of injury to the brachial plexus. Injury to the brachial plexus is an extremely dangerous problem and very difficult to recover from. So I want you to use precautions in how that patient is positioned once they are prone. You can see in the diagram, we call this a swimmer's position. So one arm is bent at the shoulder and the arm comes out at 90-degree bend of the elbow. And the head is turned toward the straight arm. That reduces tension on the brachial plexus. Very carefully change patient's position, change the arms and turn the head every 2 hours to make sure that you're not getting a lot of pressure on the face, but also that you're gently gliding that arm into the right position. One of the other areas I'd like you to think about when you put this patient into prone position is what's happening to their feet. You can see in the picture, that's the patient laying prone in bed with the feet simply dorsiflexed right on the surface, and the patient's going to run the risk of injury to the top of the foot near the ankle and of course the shin also. So you can see in the bottom picture, the patient has got their feet on a pillow, which allows the foot to be in a more neutral position. Some patients are tall enough that you can pull them down in bed and have the foot hanging off the foot of the mattress, and that's absolutely fine. It does the same thing. Do pay attention though to where you're moving or positioning a patient and where new pressure injuries actually might form. You're going to bring catheter tubes out between the legs to the foot of the bed. If you have female patients with large breasts, you're going to want to pull the breast off to the side to make sure that you're not putting a great deal of pressure on the nipple or areola. And you may want to consider using a pillow for a patient who has a big abdomen but a small chest in order to bridge that gap in the patient's anatomy. The reverse would also be true. A patient with a large chest and a small abdomen would benefit from being bridged with the pillows. Well, I'm very pleased to show you that the National Pressure Injury Advisory Panel created a set of tips for how to prone patients. And this would be a great thing for you to have on the unit for your staff. It's actually downloadable directly from npiap.org. And you can see that there are tips on where these bony prominences are when a patient's in a prone position. The next page of the tips actually goes through how to specifically position patients to make sure their head is properly positioned, the torso, the legs, the breast, and the genitalia. It's a good reference for your staff to have and to read, particularly before they place the patient into a prone position, but also a good one to refer to as far as how to do micro shifting of the patient once in a prone position. So step 2 of this puzzle is to keep the patient's skin intact during proning. The patient may actually be in a prone position for several hours at a time, and we don't have the ability to fully turn them back to offload these areas. So we've got to make sure that they're properly padded before the patient is turned over onto the prone position. So for part 3 of this puzzle, I want to turn my part of the talk over to Gail, who's going to present to you how to position this patient safely keeping your staff safe at the same time. Thank you very much. I appreciate your attention. This is Joyce Black.